Aspirin is not a vitamin. It is a blood-thinning drug, and the benefit depends on your baseline risk. That is why two people can take the same tiny tablet and get completely different outcomes. For one person, aspirin may prevent a second heart attack. For another, it may create bleeding risk without meaningful protection. The modern question is not, is aspirin good or bad? It is, what does this person have to gain, and what do they have to lose? Before we go further, do not start daily aspirin because of this video, a family tradition, an elevated cholesterol result, or a bottle that says baby on the label. Do not stop prescribed aspirin until the clinician who knows why you take it confirms the plan. A baby dose is still an adult medication. The first branch is primary prevention versus secondary prevention. Primary prevention means preventing a first cardiovascular event in someone without a previous heart attack, ischemic stroke, TIA, coronary stent, bypass surgery, diagnosed coronary disease, or symptomatic peripheral artery disease. Secondary prevention means established cardiovascular disease is already present, and the goal is preventing the next event. A medication can be strongly beneficial in secondary prevention and have little net benefit in primary prevention. The starting risks are completely different. Aspirin is called a blood thinner, but it does not literally thin the blood. It reduces platelet activity. Platelets help form clots. Aspirin makes them less likely to stick together, reducing the chance that disrupted artery plaque becomes a clot blocking blood flow to the heart or brain. But aspirin does not know whether a clot is helping or hurting. The same platelet effect that can prevent a heart attack can make it harder to stop bleeding from an ulcer, injury, or blood vessel in the brain. Aspirin also interferes with substances that help protect the stomach lining. The mechanism that makes aspirin useful against a clot is the mechanism that makes it dangerous during a bleed. Now, primary prevention. Current U.S. guidance does not recommend routine aspirin for healthy adults who simply want to live longer. For adults 40 to 59 with elevated 10-year cardiovascular risk, starting aspirin is an individual decision because the average net benefit is small. For adults 60 and older without established cardiovascular disease, the recommendation is not to initiate daily aspirin solely to prevent a first heart attack or stroke. The word initiate matters. It does not mean every person over 60 taking aspirin should suddenly throw the bottle away. Some people have a previous heart attack, stroke, stent, bypass, or another indication that changes the equation. Stopping independently can be dangerous. Why did the advice change? Modern prevention got better. More people now receive statins, blood pressure treatment, smoking cessation support, diabetes care, and earlier risk detection. That leaves fewer first events for aspirin to prevent, while bleeding risk remains. Aspirin does not remove plaque. It does not lower ApoB, correct blood pressure, reverse diabetes, or replace exercise. It reduces platelet-driven clot formation farther downstream. Aspirin is not plaque removal in pill form. The numbers explain the problem. A major analysis of more than 164,000 people without established cardiovascular disease found aspirin reduced cardiovascular events by about 0.38 percentage points but increased major bleeding by about 0.47 percentage points. That works out to roughly 265 people treated to prevent one cardiovascular event and about 210 treated to cause one additional major bleed. Those are averages, but they show why we cannot say aspirin lowers heart attack risk and end the sentence there. Relative risk shows the proportional change. Absolute risk shows whether it is large enough to matter. 3 modern trials made the shift clearer. In healthy older adults, Aspirin found aspirin did not reduce cardiovascular disease or extend survival free of dementia or persistent disability. Major hemorrhage was higher with aspirin. In Arrive, adults considered at moderate risk did not receive a significant reduction in the main cardiovascular outcome, while gastrointestinal bleeding was approximately doubled. In Ascend, people with diabetes but no known cardiovascular disease had fewer serious vascular events, but the benefit was largely offset by more major bleeding. Even diabetes does not automatically equal daily aspirin. Now, bleeding risk. Risk goes up with older age, previous ulcer or gastrointestinal bleed, previous brain bleed, uncontrolled blood pressure, liver disease, unexplained anemia, platelet problems, heavy alcohol use, kidney disease, frequent falls, or head trauma risk. Medications matter too. Anticoagulants such as warfarin, apixaban, rivaroxaban, or dabigatran can make aspirin combinations much riskier. So can other antiplatelet drugs, regular NSAIDs like ibuprofen or naproxen, corticosteroids, and some antidepressants. Never casually add aspirin to an anticoagulant for extra protection. Sometimes combinations are intentionally prescribed after a stent or acute event, but the plan belongs to the treating clinician. The higher the baseline cardiovascular risk, the more aspirin has to gain. The higher the baseline bleeding risk, the more aspirin has to lose. Age raises both cardiovascular and bleeding risk. A high 10-year score driven partly by age is not an automatic green light. Now coronary artery calcium, or CAC. CAC scanning shows calcified plaque in coronary arteries. A score of 0 generally points to lower near-term coronary risk, while higher scores suggest more plaque burden. Modeling studies suggest CAC 0 usually points away from primary prevention aspirin. A score of 100 or more may identify some higher risk people who could have a more favorable discussion, but only when bleeding risk is low. High bleeding risk produces estimated harm regardless of CAC. CAC-guided aspirin use has not been proven in a randomized trial assigning aspirin based on the scan. CAC can change the conversation. It does not automatically prescribe aspirin. Other risk enhancers include smoking, diabetes, chronic kidney disease, strong family history, markedly elevated ApoB or LDL, inflammatory disease, high Lp(a), and documented plaque. High Lp(a) may change a clinician discussion, but current evidence is not strong enough for self-prescribing. Now secondary prevention. After a heart attack, ischemic stroke, coronary stent, bypass surgery, or established atherosclerotic disease, baseline risk is much higher. The absolute benefit of antiplatelet therapy is usually much larger. Aspirin or another antiplatelet medication remains important for many of these patients. But the drug and duration vary. Some people receive aspirin, clopidogrel, temporary dual antiplatelet therapy, or a modified plan when anticoagulation is required. This is why a person with a previous stent should never stop aspirin, because a general headline said aspirin is no longer recommended. The headline may describe primary prevention. Their prescription may be secondary prevention. Now dose and formulation myths. Low-dose aspirin in the United States is usually 81 milligrams. More aspirin does not automatically create more protection. Enteric coating may change where the tablet dissolves, but it does not turn off aspirin's whole body effect on platelets or eliminate serious gastrointestinal bleeding risk. Taking aspirin with food may reduce immediate irritation. It is not a safety shield. Aspirin should not replace colorectal cancer screening. Current evidence is not strong enough to recommend starting it as a general cancer prevention or longevity strategy. So here is the modern decision tree. Bucket 1. Previous heart attack, ischemic stroke, TIA, stent, bypass, or established vascular disease. Do not start, stop, or change medication independently. Confirm the plan with the treating cardiologist, neurologist, or clinician. Bucket 2. No established disease in age 60 or older. Do not initiate aspirin solely for primary prevention. Focus first on blood pressure, ApoB and cholesterol, smoking, diabetes, exercise, sleep, weight, and diet. Bucket 3. Age 40 to 59 with low cardiovascular risk. Aspirin is unlikely to provide net benefit. Bucket 4. Age 40 to 59 with elevated risk. Important risk enhancers are documented plaque. This is the shared decision group, but only after bleeding risk and current medications are reviewed. Bucket 5. Elevated bleeding risk at any age. Primary prevention aspirin usually becomes unfavorable. Bucket 6. Aspirin combined with an anticoagulant or another antiplatelet. Review the indication and duration with the prescriber. Know the warning signs of serious bleeding: black tarry stool, red blood in stool, vomiting blood or coffee ground material, blood in urine, rapidly expanding bruising, fainting, sudden severe headache, new weakness, facial droop, confusion, or trouble speaking. Those are not wait and see what happens symptoms. The final takeaway is simple. Aspirin deserves neither its old reputation as a universal daily lifesaver nor a new reputation as a universally dangerous drug. It is a targeted medication whose value depends on the reason, cardiovascular risk, and bleeding risk. For secondary prevention, it can be life-saving. For primary prevention, especially in healthy older adults, the benefit often becomes too small to justify the harm. If this helped you understand why the answer is not simply yes or no, tap like, subscribe to Longevity Compass, and check the description for our Amazon KDP book and tools for tracking blood pressure, medications, and questions for your next appointment. Because the longevity move is not automatically taking aspirin, it is making sure the expected benefit is heavier than the expected harm.